arranging this program regularly for several months now. And today's mentor is Dr. Yatish Shantakumar. And the case is being presented by Dr. Divya Ajit, both are from Jubilee Mission Medical College. So I would like to welcome Shimmi sir. Is Shimmi sir here?
No, Shimmi is there. No, he's in Thrissur, but he's not there.
Okay, then I will request Dr. Prashant Pavitran, Vice President IAP Kerala, to say a few words.
Respected dignitaries, seniors, postgraduates, dear colleagues, under the IAP Kerala State President Action Plan 2024, we are conducting these programs, and today we are conducting the IAP Kerala, and IAP Thrissur is conducting the PG teaching program, which is going on very well. Weekly programs we are having, and Dr. Ananda Keshavan is the scientific convener, Dr. Mohandas is the state coordinator. They have taken a good lead in conducting these programs, and it's been very useful for postgraduates. And you're seeing like ranks coming out of Kerala in DNB and all, and it is most useful programs, teaching programs of IAP Kerala. And also today's faculty, Dr. Suma Balan from Amrita Kochi, and also I would like to thank him for joining in for the program, and Dr. Yatish Shantakumar from Jubilee Mission, and Dr. Divya will be listening the case. And it is on edema. Last week we had a splenomegaly case, a good case discussion, and Dr. Latika also I would like to thank for the wonderful coordination, a zonal coordinator she has been doing over the year. Best wishes to this program of IAP Kerala and IAP Thrissur. Thank you, JIP, Jai Hind.
Anandageshwan sir, our scientific convener, for a few words. Anandageshwan sir, please. Now I would like to request Dr. Latika to introduce the speaker.
Good evening, all. So today's lead discussant is Dr. Suma Balan. She's well known to all and doesn't need any introduction. She is the professor and HOD of Rheumatology and Clinical Immunology, Amrita Institute of Medical Sciences, Kochi. And she is the pioneer of pediatric rheumatology in Kerala. So I take this opportunity to thank Madam for accepting our invitation in spite of her busy schedule and chair the session. And now I hand over to the mic to Dr. Yatish Shantakumar to introduce the case as well as the presenter.
And you are muted. No, not audible.
Okay.
Now?
Yes.
Good evening to all esteemed IAP members, and greetings on behalf of the Pediatric Department of Jubilee Mission Medical College. I thank the IAP organizers, Dr. Suma, who was so gracious to lead the discussion today. And I also acknowledge the efforts of Dr. Shiji Joseph from Amla, who has helped us to work up the case. I introduce today our third-year postgraduate, Dr. Divya Ajit, who will present the case. It is a case which presented with edema, and we could come to a diagnosis after much deliberation, after history and examination, and Dr. Divya will present and let us know more about the case. Over to Divya.
So before starting, I will mute all now, and Divya and Suma Madam can unmute, and others can unmute when they want to speak. Yes, Divya, you can start. You can unmute and okay. Suman, okay, you can start.
Good evening, all. Welcome to today's clinical case presentation. Today, I'm going to be presenting the case of a 10-year-old girl, Minha Fatima, whose residence is Shelur, and informant is mother, and information is reliable. The date of admission was on 18/4/24, and date of examination was on 21st/4/24. Presenting complaint: the child presented with complaints of facial puffiness for 5 days, painful swelling of right angles for 5 days, purulent eye discharge 5 days back. 10-year-old girl presented with complaints of facial puffiness, which was more during the day after awakening and subsides by evening. No history of any generalized swelling. History of swelling over the right angle since the past 5 days, which was followed by pain on movement. It was progressively increasing over time. History of difficulty in walking present. No history of diurnal variation associated with the pain. History of purulent eye discharge associated with occasional cough and running nose since the last 5 days, which has subsided on symptomatic medications. The child had no history of reduced urine output, frothing of urine, blood-stained urine, cola-colored urine, dysuria or increased frequency of menstruation. History of any abdominal pain, vomiting, headache, seizures, or altered behavior. No history of breathing difficulty or generalized swelling of abdomen or body. No history of rash or photosensitivity or hair loss or oral ulcers or tiredness. No history of fever. No history of trauma or insect bite or drug intake. No history of dryness of mouth, reduced vision. No history of loose stools, blood in stool. No history of night pain, significant weight loss or loss of appetite. No history of travel. The child was treated with some analgesics and antibiotic. The child was brought here as the symptoms were persisting. After admission to the hospital, the child developed left angle pain followed by swelling with difficulty in walking. By the second day of admission, the child developed painful swelling over the right wrist joint with difficulty in movement. The pain over the right angle joint was persisting as the other pains developed. No history of any small or axial joint involvement. No history of nodules over skin or abdominal movements of hands. Past history. History of throat pain and fever.
Divya, before you go into the past history, can you just tell me what's going on in your mind from the presenting complaints? What kind of conditions are you thinking of?
So the child is presented with a history of facial puffiness and swelling of ankle joint, which was followed by pain over the joint and difficulty in walking. And there was additive involvement of other joints such as left ankle joint and the right wrist joint. So it's probably
So are you dealing with an acute story or a chronic story, do you think?
Now it seems like an acute story.
Okay, fine. So you're dealing with an acute story of a combination of some inflammatory arthritis along with?
Probably a region.
Okay, fine. Okay, carry on.
Past history. History of throat pain and fever 2 weeks back, for which the child was started on some oral medications. No history of any similar illness in the past. No history of rash or joint pain in the past. No history of loose stools or blood in stools in the past. Antenatal history was uneventful. Natal and postnatal history, the child was born at full term via LSCS in view of non-progression of labor, cried soon after birth. Birth weight was 3.3. There was a history of yellowish discoloration of body for which the child was given phototherapy. There was no history of breathing difficulty, feeding difficulty, bluish discoloration or seizures. Developmental history, the child is studying in 4th standard with good scholastic and post-scholastic performance. The child is immunized according to national immunization schedule. No optional vaccines were taken. BCG scar was present. Diet history. The child is getting a calorie of 1,800, where the requirement is 210 kilocalories with a deficit of 210 kilocalories. And there is no protein deficit. The child is taking adequate green leafy vegetables and fruits. Family history. This is a firstborn child of a non-consanguineous marriage. There is a history of suspected rheumatic heart disease in father. Valve replacement was done at 12 years. The father is still on some medications. There is no other history of arthritis, skin disease, or bleeding disorders. There is a history of death in first cousin 2 years back. The child was said to be diagnosed with shock and multi-organ failure.
Did you have 2 years back means 2022?
2022.
Really? I don't know. Generally, our experience is that by 2022, MISP was over actually. So it seems unusual.
History was similar with swelling of legs, and the child suddenly went into multi-organ failure.
Okay. Yeah. Carry on.
Socioeconomic status, they belong to lower middle class according to modified Kupasamy classification. They live in a Pakka house, 3 rooms, no overcrowding, separate toilet present, no pets or smokers at house. Summary, 10-year-old girl with normal development presented with complaints of painful swelling over right ankle, puffiness of face for 5 days, followed by left ankle pain and painful swelling over wrist joint. There's a past history suggestive of pharyngitis 2 weeks back and a history of rheumatic heart disease in father. So with this,
yeah, so come to your differential diagnosis from history.
So with this history, this is probably a connective tissue disorder. Differential diagnosis of post-streptococcal reactive arthritis, or it can be post-streptococcal glomerulonephritis, rheumatic fever, reactive arthritis, systemic lupus erythematosus, JA or vasculitis.
Can you actually go through each of these and tell me which you think was your first thought when you saw this child? From the history you have, the duration you have, findings comes later, but from the history you have, what do you think are the most likely possibility at this point?
Post-streptococcal reactive arthritis. There was a history of throat pain and fever about 2 weeks back, followed by which the child developed the puffiness and swelling over ankle joint, which was followed by pain.
But post-streptococcal reactive arthritis should not have facial puffiness and the other thing. So are you saying the patient had both APSGN and post-streptococcal reactive arthritis happening together?
That is the factor against post-streptococcal reactive arthritis, because facial puffiness was there and edema of legs was there. We could have also considered post-streptococcal glomerulonephritis, but there was no typical history of hematuria or polar-colored urine.
Okay, but it could have been a combined. Could have been a combined presentation.
Could have been.
There is no rule that a patient cannot get both clinical syndromes if they've got a streptococcal infection, right?
Yeah,
Streptococcal infection can also, trigger off Henoch-Schönlein purpura in patients. So there are many things that bugs can do. Okay, so you can consider a combination of both pathologies happening together here. It is possible. What else? What do you think about the possibility of rheumatic fever? Would you keep it on this list at all?
Polyarthritis with the previous history of.
Where is the fever?
There is no fever.
There's no fever. That itself takes it out. Okay. The second thing is what you're having is an additive inflammatory arthritis and not a migratory arthritis. Okay. Children with rheumatic fever or acute rheumatic fever are actually very sick. They're in a lot of pain. They don't ambulate at all. The joints are very large. They're very big, and then they move from one to the other. So again, I think I actually wouldn't put rheumatic fever in this list. The first two, I completely agree with you. It is possible. Okay. Then the other thing would be Okay, then what do you mean by reactive arthritis?
Reactive arthritis is arthritis that is happening as an immune response to a infection. It can be due to a gastrointestinal or urogenital infection. Post a gastrointestinal or urogenital infection, the child may develop arthritis.
Okay.
But,
Again, how
that-
would you explain the facial puffiness and all with the reactive arthritis?
That could not be explained.
It's unusual. Yeah. Okay.
Unusual. Otherwise,
Yeah.
uh,
Yes.
then
So reactive arthritis is basically an immunologically mediated arthritis following an infection where the infective agent will no longer be found at the point of findings. Okay. Right.
okay.
I mean, post-streptococcal reactive arthritis is one of the examples. Actually, it's a very wide spectrum of arthritis, and when we have specific organisms, we name it post-streptococcal reactive arthritis like that. But the general term is reactive arthritis. Then your next point, what do you think? Would you actually think of SLE at this point with 1 week history? What
No,
are your
ma'am.
reasons for thinking about it?
The reason for thinking about SLE is there is like two system involvement, musculoskeletal and renal involvement is there, but the
Okay.
duration is not.
What is the
that
usual
it's-
duration that you expect to see SLE in?
It's usually at least more than 2 weeks, at least more than 2 weeks. Subacute or chronic arthritis present.
Actually, that's not true. SLE is such a surprise package. It can come as a chronic disease, it can come subacute, it can come acutely too. Like a week's story is not impossible for SLE. But I agree with you. It would not be top diagnosis at this point. However, 10-year-old girl, what is specific about being 10-year-old?
That is 11 to 12 years is the most common age group of SLE.
So peripubertal age group. Okay. So one theory which has a lot of weightage is that the hormonal changes around puberty is something that does trigger off the lupus pathology in genetically determined host. Okay, so it's a multifactorial etiology. So around this age group, in a girl with multiple systems involvement, it should be in your mind. Though I completely agree with you, I would not put it at the top of the diagnostic table at this point at all. What about JIA?
JIA, the criteria of arthritis, especially in chronic arthritis.
I actually wouldn't put JIA at this point. I wouldn't think of it because your history is too short. Okay, it's too short. And the other system involvement with the puffiness and all simply doesn't go with it. Okay, what's the definition of JIA? Clinical definition?
JIA is defined in a child more than less than 16 years old with an arthritis of more than or equal to 6 weeks.
And how do you know that the child has arthritis? What are the features on which you base the diagnosis of arthritis?
Arthritis is either swelling or effusion in a joint, or two or more of the following, such as pain, warmth, restriction of movements.
Most JIA joints are rarely warm, actually. It's more about having, yes, definitely swelling, synovitis, effusion, or restriction. So if you're looking at deep joints like the hip and the shoulder, it's very unusual to see swelling of the joint. Whereas the knee and the ankle and elbow, you can see swelling of the joint directly. So for the other joints, you have to look for restriction. Stiffness, restriction, synovitis. These are the features. And as you said, There has to be a certain chronicity to the symptoms to actually term it JIA. JIA is definitely extremely low in consideration at this point in time. Okay, this child has more of acute symptoms. Okay, now your next thing, vasculitis. What kind of vasculitis would you think of here?
You can think of medium vessel vasculitis, such as polyarteritis nodosa, but that is also not because rash will be there, cutaneous manifestations are not there. And it's a female. So
No, that's got nothing to do with. So when you say polyarteritis nodosa, there are two types. What are the two types?
there is cutaneous pan and
Systemic pan. Okay, so cutaneous pan can present with some arthritis, but the skin involvement is really important. You will have paniculitic lesions, you will have livedo reticularis, you will have erythema nodule, you will have various things, you will have vasculitic edema. So all the features of medium vessel involvement will be there. And those features are not there here. How would you explain the facial puffiness, etc. with pan? If you're considering pan, how would you explain that?
there is renal involvement.
What is the nature of the renal involvement in pan usually? Cutaneous pan usually will not have a renal involvement by definition. Systemic pan can. What is the nature of the renal involvement usually?
Renal artery will be involved.
Stenosis. So how does that present? Renal artery stenosis will present clinically as? You'll get renal artery aneurysms, beaded aneurysms in the renal arteries, and that will present as hypertension. It can also present as a secondary nephrotic syndrome in some patients. So from that point of view, you might get facial puffiness, etc. But these patients, systemic pan patients, are very, very sick. They have high-grade fever. They'll have, a multitude of multi-system features, and they are not clinically very stable. They're very sick patients, actually, most of the time. Okay. Now we're talking about all this reactive arthritis, various things. Your patient had a respiratory infection 2 weeks prior. Is there one more infection? Actually, when you talk about vasculitis, is there one more condition that you need to think of here? Far more common. Of course, a cardinal sign is missing, but still, no. What about IgA vasculitis, Henoch-Schönlein purpura?
Rash is not.
Would you consider it's not there? That is true. But you have 1 week history, the patient, you're presenting the initial findings to me. Sometimes patients don't read textbooks, the rash can come later, or they can have minimal rash. So one thing about the rash of IgA vasculitis is it does increase when the patient is mobile. So if your patient is kind of, not moving much because of arthritis in the leg or something like that, the rash may not be that prominent initially. Though, of course, you do need the rash somewhere to make a diagnosis. But that is also something to keep in mind. This might become manifest as the days go. Okay, that is definitely something to think about in this case. Okay.
Okay.
There is one more infection I want you to think about in this presentation. It's okay if you don't get it now. We'll come to it later. Okay. Yeah, carry on. Right.
Examination, general examination. The child is active, alert, right? Vitals, of 90 per minute, regular rhythm, normal volume and character, no radial or radiofemoral delay. Respiratory rate of 24 per minute, BP of 128/80 in the right arm in supine position, that is more than 90%, right?
Divya, just
Divya, can I just interrupt one thing? If the patient had a problem with the pulse, let's say the radial pulse was lower in volume compared on one side compared to the other, would you think of another possibility here with this presentation? Definitely, yes. Yes. That's also something to think about in the background. Okay. These kind of there can be a lot of non-specific symptoms. Yeah. Yes, sir. Dr. Kushan.
Divya, in the evaluation, you're well discussed there, both of you. And in the puffiness, when you are getting the puffiness in the eyes, you need always consider and answer whether the puffiness is local reason or systemic, rather than jumping on to concluding that renal involvement. So definitely there's a hard finding of a joint involvement, multiple joints are involvement. Definitely arthritis there. In that context, puffiness need not always indicate the renal involvement. There are multiple reasons for local edema like puffiness situation, like the vasculitis part, or maybe one entity which we need to consider is a superior mediastinal obstruction, where there can be puffiness alone in the upper territory, lower territory. So you need to mention about the right side angle. Was there any edema? Left-sided angle involvement is arthritis. There is no involvement of the right side angle. Was there any edema on the right angle part? And about the abdomen and the umbilicus. So if there is involvement only, you need to consider renal involvement. It's persistently puffiness only, and the lower part is not involved. So whether it should be considered as a renal involvement or another way of the puffiness situation, which also can be explainable with this in this context. So don't brand that renal possibility. It can be other way also. We can discuss with in that situation, the second possibility you consider acute glomerulonephritis part. What is the usual situation? You will be getting puffiness with other areas also. Pure puffiness only is less likely. And the other thing, you didn't give much importance to the purulent conjunctival part. So you just moved on without giving much importance. But how long it persisted? Just short duration only?
Only short duration. It was relieved by the time she came here.
Okay. Proceed.
She was basically, we were just at history. So I think many of the points Sir says are important and become more relevant to discuss after the examination is presented, examination findings. Yeah. Carry on with it.
Capillary refill time of less than 3 seconds. Equally, peripheries are long. Pallor was present, bilateral jugular-digastric node enlarged, 1.5 to 2 centimeter, non-tender, soft, non-matted, no icterus, cyanosis, clubbing, or generalized lymphadenopathy. Actually, bilateral pitting pedal edema was present, but right side was more than left side. Head to foot examination. Head, no hair loss, face, no rash over the face, eyes, mild periorbital edema, no redness, no cataract, ears, fundus examination was normal, ears normal, oral cavity, no ulcers. Trunk, no rashes, upper limb, swelling of the right wrist joint present with tenderness, lower limb, bilateral angle joint swelling present with tenderness, nails normal, no pitting, external genitalia, no ulcerations.
Can I just ask you, Divya, when you said oral ulcers, what kind of ulcers were you looking for?
After ulcers and Behçet's disease and SLE ulcers.
What kind of ulcers do you tend to see in SLE? Are they symptomatic? Akshaya's iPhone is correct. Usually painless ulcers. Where are they seen? Where do you expect to see? What are all the oral findings you can see in these patients? Yes, you see the ulcers on the hard palate. Okay, so this is something that is important. The patient will not complain to you. They may not even know. And they can actually have pretty large lesions sitting there in that hard palate. You have to shine your torch in, open the mouth and look at the hard palate to look for these ulcers. So these are not aphthous ulcers that you see. You can see mucositis in SLE. You can see, mucosal changes. For sure, you can see them. If they are present, they are obvious. You'll mention them. But you have to look. This is pathognomonic. When you see the hard palate ulcer, it is pathognomonic for SLE. Okay, so that is something you have to learn to look in at the palate, shine your torch, and look for the erosions or ulcers. Okay, they are often asymptomatic. Very rarely are they symptomatic. Okay, carry on.
Anthropometry, weight is 24 kgs between 10th and 25th centile. Height is 133.5 centimeter between 25th and 50th centile. BMI is 13.5 between 5th and 10th centile.
Okay.
Going into systemic examination, abdomen examination, upper GI, no oral ulcers, throat.
Actually, well, can I interrupt you again? Just go back to that growth chart you had. So what is the importance? Like here, you have only 1 point measurements. So it's difficult for you to know, but it would be useful in a case like this. So sometimes the history can be non-forthcoming. We might have to go back and ask a lot of leading questions. It would be useful to see if you can chart any previously available weight and height, so that to see whether this patient is actually not thriving for some time. Okay, that gives you an idea whether there is potentially a chronic disease going on for a while, and even though the family hasn't realized it. Okay, so it's always useful in such cases to see from the parents if you can get hold of maybe, you know, in the last couple of years, a couple of weight and height, and if you can plot it, it gives you more information about the long term, what has been happening with this child. It could well be that she's a small child and she is growing consistently on these particular centiles without any, and that happens. A lot of children are like that. That's fine. Just a point. Carry on.
Divya, a previous slide growth chart. There is a small mistake in that chart. What is that mistake?
Marking.
In the height year marked on the 9th year, and actually
Yeah.
it becomes
Correct.
25th centile, not 50th centile. Okay.
Yeah.
Okay.
You mark 1 centile above. That's right. Yeah. Very well seen, sir. Okay. Can you all hear me now? Oh.
Yes, ma'am. We can hear you.
Carry on, Vivek.
Systemic examination, abdomen examination, upper GI, no oral ulcers, throat normal, inspection, no abdominal distension, umbilicus in midline, normal, inverted, all quadrants move equally with respiration, no visible pulsation, scars or swelling, skin over the abdomen normal, hernial orifice is free, palpation, no rigidity or guarding, non-tender, no palpable mass, no fluid thrill, percussion, liver span 8 centimeter, no shifting dullness, auscultations, bowel sound heard. Cardiovascular system, apex beat felt at the 5th intercostal space, medial to the mid-clavicular line, normal character, no elevated JVP. S1, S2 heard, no murmur. Respiratory system, normal vesicular breath sounds heard, no added sounds. Central nervous system, no meningeal signs, higher mental functions normal, no cranial nerve palsies, normal motor and sensory functions. P-Gals evaluation. Gait on standing, no limb shortening, rashes or scars, difficulty in touching the heel on down pressing. On walking, there is a difficulty in walking on heel. Arms, mild pain in wrist joint extension. Legs, knee and hip joint movements were normal. Spine normal. Musculoskeletal system examination. Examination of foot and ankle, swelling present over both ankle joints. Tenderness present, local rise of temperature present, restriction of movements and passive movements, peripheral pulse is felt. Examination of hand and wrist, swelling of right wrist joint present, tenderness present, local rise of temperature, restriction of movements and passive movements of the wrist joint present. Peripheral pulsations and sensation were felt. Summary, a 10-year-old girl with normal development and immunized up to age presented with history of painful swelling over both ankle joint and right wrist joint with facial puffiness and purulent eye discharge. She had a history suggestive of pharyngitis 2 weeks back and a family history of rheumatic heart disease in father. On examination, the child was found to have pallor, periorbital edema, hypertension, and arthritis of both ankle and right wrist joint. Systemic examination was found to be normal. So with this,
Okay. Okay. So now come back to what are your possibilities? Tell me why you want to put systemic lupus erythematosus first.
Because there are two system involvement, there's hypertension, mild periorbital edema, pedal edema, along with arthritis.
Why would you think of a post-streptococcal illness as your first diagnosis here?
Both glomerulonephritis and reactive arthritis very rarely occur simultaneously.
Okay. Yeah. Okay. Fine. And what about vasculitis? You want to put it lower down. You still want to have rheumatic fever in number 4. I would actually eliminate that from the list of possibilities here. Okay.
Okay.
Okay. That's fine. I think now what are you going to do? How are you going to work up this child?
Investigation first, basic blood counts, hemoglobin, total count, WBCs and platelet. Then inflammatory markers, ESR, CRP. Then urine analysis. Then renal function test. Then we can do ASO titer.
Okay.
Then if ESR CRP is elevated, we can go in for ANA profile.
You want the CRP also to be elevated?
No, ESR elevated.
But ESR elevation is not specific, no? It can be elevated in any of the differential diagnoses you have put there. It's not specific for SLE as such, right? So one thing is clear, you're dealing with an immunologically mediated disease.
Yes.
Okay, I think that is pretty clear. You're not dealing with an acute infection or something here. That is the first thought process that needs to go into your mind. You are dealing with something that's from the history you have, it seems to present acutely. It is involving two systems, and it definitely appears immunologically mediated in a 10-year-old female child. So definitely, I agree, lupus has to come in a differential diagnosis. Because if you don't think about it, you won't diagnose it. That is very, very true. Whether you want to put it first or second, that's okay. I don't think we need to quibble on that. So do you want to go ahead to what you have done, what workup you have done?
Investigation finding, HP was found to be low, 9.7. Total count was normal, platelet was normal. CRP was slightly elevated, 1.69. ESR was 108. Initially, the RFT showed creatinine.
So before we go to the rest, how do you interpret this particular blood count?
Normal and anemia with normal leukocyte count.
Okay. When you're looking at a leukocyte count, what are the components you look at?
Neutrophils, lymphocyte is.
Okay. So what is your comment on the neutrophils and the lymphocytes here?
Neutrophils are 49% and lymphocyte is 36.
Yeah. So they are within what is a normal range for lymphocytes?
60.
When would we call lymphopenia?
Lymphopenia.
So that is something you need
20
to
plus.
learn to keep doing, because it's most of us look at a total count, we look at the neutrophil count, and we are happy if that looks normal. We also have to look at, in this case, your lymphocyte count is normal. You have a lymphocyte count of approximately 1/3 of the 6,700, which is around 2,200. It's kind of, there are some definitions which say lymphocyte count below 2,000 is lymphopenia, and some which say below 2.5 is lymphopenia. In that definition, you would be lymphopenic here, but it's very, very borderline. But it is important. Suppose this had been lymphocytes of, say, 20%, for instance. That would be very significant in this particular child. Okay, so learn to recognize lymphopenia as well when it is independently existing, because certain conditions like lupus classically have lymphopenia in the count, and that is a subtle feature that often gets missed. Okay, and when you put up the count for these patients, you should be telling me what the MCV is, what the MCH is, and what the peripheral smear told you. Why?
Because there can be hemolytic anemia.
We want to know what kind of anemia the child has, right? So we need to know the MCV and the MCH in these patients. Retic count, if you have it available, is useful, but definitely the peripheral smear appearances. That is important. Okay. All this is going to help you with trying to refine your diagnosis as you interpret your investigations. Okay. Then your CRP and ESR, what do you make from that?
ESR is markedly elevated, CRP is slightly elevated. So probably an inflammatory.
So what do you think? Looking at your differential diagnosis that you had, what kind of conditions would fit into this? So you're looking at post-streptococcal reactive arthritis. What do you tend to see with the inflammatory markers in post-streptococcal reactive arthritis?
CRP will be a bit more elevated.
Definitely. They'll be more or less proportionate. Okay. You'll get CRP and ESR elevation. There are certain pathways through which inflammatory markers evolve. CRP usually evolves through the IL-6 pathway, and the liver is responsible for generating IL-6. It comes through the IL-6 pathway. If you have significant liver disease, sometimes you cannot mount a CRP response. That's not relevant in this particular case. If you have anti-CRP antibodies, you may not mount a CRP response. Okay, so there are many reasons. So one of the classic conditions where you have inflammation with an ESR rise, but the CRP is normal, is actually SLE. Okay, so most of the other, like rheumatic fever, you will get both high CRP and high ESR. You will not get only such a disproportionate thing, you will not get. Okay, similarly, most of the vasculitis also, you will get high CRP and high ESR. It won't be just the ESR alone that is elevated. JIA, again, in some forms of JIA, you may not get any inflammatory marker elevation. But if you get, you'll usually get proportionately both being elevated rather than just one. Okay, so that is again something to look at when you're interpreting both of these together. It gives you a clue to what might be an underlying diagnosis here. Okay. Now, there are some exceptions to this rule, and I see a question coming up there. So, let us say, in a patient of SLE, when can CRP be elevated?
Acute.
So, when there is inflammation of any membrane. So, actually, if you have synovitis, like in arthritis, sometimes it can be elevated. If you have serositis, so pleuritis, pericarditis, ascites, you get a very high CRPs in lupus patients. And the most important, a lupus patient who comes to you with a bacterial infection will have a high CRP. So these are the situations where lupus has a high CRP. Most of the time in lupus patients, we do not see a high CRP even when the disease is active. Okay, so that is where these tests kind of try to fit into a jigsaw. Okay, then walk me through the rest of the tests. What are you seeing? Do you remember what the MCV was for this patient out of interest?
It was normocytic.
Normocytic, normochromic. Okay. So that, what does that suggest to you? What could be the cause of this?
Can be chronic inflammation.
Can be also?
It can be either chronic inflammation or blood loss or hemolysis.
Yes, exactly. Okay. Right. So now walk me through the rest of the investigations that you saw.
Renal function test done showed high urea initially 76. Next day repeated it showed 44. That is a pre-renal. Urine routine initially done showed an RBCs of 8 and protein trace. Then the next day, which was repeated, it again showed an RBC of 20 and protein was traced. There was microscopic hematuria. PC ratio was 0.29, slightly elevated. Direct womb test was positive 3+. Then peripheral blood smear done showed mild normocytic normochromic anemia. ASO titer was also done, that was actually low. Then because hematuria was there, C3, C4 was done. Both C3 and C4 were significantly low. ANA was done, which showed 1:80 dilution, 1 positive, nuclear speckled pattern, minimum fluorescence. ANA profile was weakly positive for SMD1. The other investigations were normal. Rest of USG.
Okay. Now with this picture, what if your ASO titer had been 2000?
It could have been a post-streptococcal.
You think so? What does ASO titer suggest?
There has been a previous streptococcal infection.
There has been a recent streptococcal infection. That's all it suggests. The rest of it has to come from your clinical context. Okay. So in your clinical context, if you have a patient who has clear evidence for a post-streptococcal reactive arthritis or nephritis or whatever it is, then that ASO titer helps you with making that diagnosis. It is only contextual, purely circumstantial evidence. It does not make a diagnosis on its own. It is definitely indicated in this particular case with this presentation to do an ASO titer. I agree. If this child had come to you with a 2-month history, it's probably irrelevant to do an ASO titer. But in this history, it is definitely relevant to do one. Now you're seeing C3 and C4 both extremely low. What's your inference from that?
There is hypocomplementemia. If it was PSGN, usually C4 is normal, C3 is low.
Then?
Hypocomplementemia can happen in lupus nephritis.
Only in lupus nephritis? Why is there hypocomplementemia? Why does it happen? What does it mean if there is hypocomplementemia? What are the situations medically where you can get C3 and C4 coming low? What does it mean from a pathological point of view?
It can either be due to increased usage of complements or due to loss of complements.
Yes. Okay. So increased usage means, what are you talking about? What kind of a pathology are you talking about?
Autoimmune or inflammatory.
So an immune complex mediated pathology. Okay. Now, which organ in the body synthesizes C3 and C4? Again, it's the liver.
Okay.
Okay. So if you have severe liver disease, you can get very low C3 and C4, and you should not assume the patient has lupus. Okay, that's an important thing. Another thing is, are there infections that can cause both C3 and C4 to come down? The infections that can cause immune complex mediated pathology in their immediate aftermath. As you said, post-streptococcal, most of the time, it is C3 that is low. But sometimes you can get both going low. If the process is that severe, okay? Say in an RPGN kind of setting, sometimes you can get C3 and C4 coming low. Mycoplasma is an infection where you can get autoimmunity, you can get both C3 and C4 coming low, you can get a nephritis, you can get arthritis, you can get this entire clinical picture actually. Okay. And your patient did have fever and a respiratory tract infection 2 weeks prior. It is a differential diagnosis. However, this is profoundly low hypocomplementemia. So blaming it entirely on mycoplasma is, DCT positive hemolytic anemia, very common with mycoplasma. But if you're having an immune mediated vasculitis with mycoplasma, again, you usually get a high CRP as well, in addition to the ESR being high. So the pathology goes like that. It's not like lupus. Lupus has many reasons for CRP to be low. And those reasons don't hold good for mycoplasma. But remember, that is actually one post mycoplasma related can be something that can explain many of the features that you are having in this patient. Okay. So that is something also to think about. Okay. Your USG abdomen is normal. What is the most important thing you wanted to see in that USG abdomen?
Whether there is hepatosplenomegaly or pan.
Why would you expect hepatosplenomegaly?
Anemia is there. Other cell lines are normal.
Your patient is only like 1 week history, 10-day history. So probably not enough time to get that kind of lymphoproliferation going on. Okay.
Renal.
Yes, actually that would be more important to see if there is look at the renal echogenicity. That would be a more important reason actually to look at in that thing. See if there is an ascites, increase in the renal echogenicity, the corticomedullary differentiation, that kind of thing. Though, again, your patient's renal involvement is very much there, but it is not very, very massive. So, and the history is relatively acute, so you may not immediately see changes in the ultrasound. If it was there, it is helpful. If it is not there, it doesn't eliminate. It's that kind of thing. Okay. Did you do an anti-dsDNA separately, an ELISA?
Yeah, after this anti-dsDNA was done, that is negative.
That is negative. Okay. Now, what your comment on the ANA test done here? How significant is this?
A dilution of more than or equal to 1:8 is considered significant.
So the good thing is that you have done an ANA by immunofluorescence. What are the different ways in which ANA is done? So this is an ANA screen. So remember, there are two different things. The ANA screen is basically just looking at the nucleus as a whole to see if there are anti-nuclear antibodies. The ANA profile further typifies against which nucleolar element these antibodies are present. Gives you further detailing. A common mistake that a lot of people do is they think doing an ANA profile is easy. You don't need to do a screen, but you should always do a screen first and a profile later. Okay. And there is no point, there is no value in doing a profile if your ANA screen is negative. Okay. And ANA screen should always be done by immunofluorescence and not by ELISA. ELISA ANA that is currently available is a test with both, which is very unreliable. Immunofluorescence is a much better test, much more reliable, believable test, way of checking ANA. It is more expensive than an ELISA. But ELISA, both positivity and negativity, the risk of false, both positivity and negativity is very high compared to an ANA done by immunofluorescence. Okay. Regarding titers, when you have the higher titers, it makes more sense. Okay. However, there is also something, there is an important phenomenon where you can sometimes, when you first test, I don't know whether you've ever seen an immunofluorescence being done, but it's a very interesting test, the way it gets done. So sometimes what happens is you can falsely get a low titer, even though actually your ANA can be, the titer can be considerably high. Okay, that is because sometimes you may need to dilute this further, the sample further, and then you will actually get the actual titer subsequently. The real thing is that normally we say greater than 1/160 is significant. At 1 in 80, it is positive, but you have to interpret with all the other clinical features that you have. Okay. So the interesting thing is your patient is having significant hypocomplementemia, is having an DCT positive hemolytic anemia, is having some features of a nephritis, but the immunological testing for the antibodies is of relatively low yield at present. That does not rule out the diagnosis, but it is something to keep in mind. Okay. Perhaps repeating in a different lab sometimes may yield a different result for you. That's something to think about here. But still, it's not something that you say it's very borderline, so I'm not going to regard it. That's not true. You will still take it significantly. Okay. So now how do you want to put all this together?
So according to the ULR criteria for SLE, it actually, according to ULR criteria, score comes to about 20 in this case.
So what is the score? What does this mean? What does this criteria mean? Are these diagnostic criteria or are they classification criteria? What is the difference?
Diagnostic criteria is diagnose whether the patient has SLE or not. Classification is to classify into mild, moderate, and severe.
No. So classification, these are classification criteria. They were devised because when you're doing trials in patients, you need to have patients who fit the diagnosis, and only then they can be enrolled into a trial. So criteria were designed, they're called classification criteria, so that patients can be classified into a trial. They are not diagnostic criteria. Many rheumatological conditions have classification criteria and not diagnostic criteria. One condition that has diagnostic criteria is Kawasaki disease. Most of the other criteria come across are actually classification criteria. And a patient may not sometimes fulfill classification, necessary classification criteria the first time you see them. They might fulfill over a period of time. Okay, so the overall clinical context is very, very important. And what you're saying here is your patient will fit in the classification criteria because there are several positivities in this patient. Do you know what this particular criteria is called?
Euler or ACR.
It's called the SLIC criteria, Systemic Lupus International. What? Okay, you can SLICC. You can go and check it. Okay, fine. So by this criteria, yes, she does fit in with a possible diagnosis of SLE. Agreed. What next? Is it enough just to make a diagnosis of SLE?
No, we should see whether it's mild, moderate, or severe. Check for other
More than mild, moderate, or severe, we actually mean what domain involvement is there. Minor organ, major organ, catastrophic, severe, that kind of thing. Okay, that is the most important thing that is going to determine your next level of action for the patient. Okay, so from that point of view, what would you think your patient has? With the presentation you've given me,
might have lupus nephritis.
yes, yes. And what is that called? If it's lupus nephritis, what is it called?
Depending on
So you have cytopenias, you have a hemolytic anemia, you have arthritis, and you have
lupus nephritis.
Yeah, a good possibility of lupus nephritis. Okay, so what should you do now for this patient?
The patient actually should undergo renal biopsy to
Yes.
classify.
Now the problem with that thing you put there, renal proteinuria more than 0.5. Please remember that most of these things are made for adult patients. When you have a single number, it's always meant for surface area 1.73. Pediatric patients come in all sizes and shapes, and we usually will have this many milligram per kilo or milligram per meter square and that kind of definitions. So, to be honest, we do not look at proteinuria more than 0.5 grams for 24 hours for a pediatric patient to decide whether a renal biopsy should be done or not. Okay, we see if there is evidence, clinical evidence of a nephritis, if there is any proteinuria or active urinary sediment. Hypertension is there in this case as well when the patient came. So these are reasons to consider strongly that the patient has a renal involvement. Okay, and in my book, this child qualifies for a renal biopsy. What are the reasons? Why do you need to do a renal biopsy? You can say that patient fulfills criteria for lupus. Patient clinically seems to have nephritis. Why do we need to do a renal biopsy to prove it?
To classify into one, if it's more than 3 or 4, you need to start other medications such as cyclophosphamide or mycophenolate. Treatment purposes.
So basically, how do you classify lupus nephritis? How many stages are there? How many classes are there?
There are 6 classes. First class is minimal mesangial. Second is mesangial proliferative. Third is focal proliferative, that is less than 50%. Fourth is proliferative. Fifth is
diffuse proliferative.
Diffuse proliferative. Then fifth is membranous. Sixth is sclerosing nephritis.
Yeah. So class 6 is basically the patient is going to lose kidney function. You need to start preparing for a transplant. Don't go for active lupus nephritis treatment at that point. Okay. Class 1 and class 2, you would treat lupus based on the rest of the weight of lupus in that patient. Class 3, class 4, class 5 are all called proliferative lupus nephritis. And this class is very, very important. Okay, because here you are given an opportunity where you can actually get the kidney function back to normal and preserve the kidneys for good long-term outcome. And appropriate aggressive treatment is important to determine that. Okay, and that is why you need a renal biopsy. Class 5 is a little tricky because class 5 can sometimes have some reversal features and some chronic features which may not be easy to reverse. But still you can try. The way class 5 can be mostly proteinuria. You can also get podocytopathy in lupus. And those patients again will have mostly proteinuria but less sediment. So there are a lot of information you can get from a renal biopsy. When you do a renal biopsy, what all would you do? How many specimens do you think the nephrologist should take?
Immunofluorescence, electron microscopy.
So first thing is
Normal.
the light microscopy.
Light microscopy.
Okay, so the light microscopy and immunofluorescence are what we universally do. There are specific conditions where electron microscopy helps, particularly if you suspect a podocytopathy. Okay, we rarely, because electron microscopy is expensive, available only in very few places. So we are usually guided by the pathologist to see whether it would be worth doing an EM on the biopsy. Okay, but light microscopy and the immunofluorescence are vital. Okay, why is that? Why is immunofluorescence so important?
Immunofluorescence in lupus nephritis, there is actually the all immune complexes will be present in.
Yes. So it's called full house. It's called full house. So basically, when you play cards, when you have all the winning cards in a deck, it's called a full house. Similarly, when you do a kidney biopsy in lupus nephritis, you will find all the antibodies that you can see in the biopsy, and therefore there is no differential diagnosis to a full house immunofluorescence with proliferative nephritis. If you have a proliferative nephritis with a full house on immunofluorescence, there is no differential diagnosis. This patient has lupus nephritis. Okay, so it is that powerful, the description there. Okay, and the important thing is that, do you think sometimes we can predict based on the clinical findings what the histopathology will be, but it's not always consistent. Okay, sometimes you can see even with a 1 week history, you can actually see a very high activity score, diffuse proliferative nephritis. Okay, so you cannot completely go by the clinical context and say that this patient will not have proliferative nephritis. That is the important thing. So that is why, especially in children, what is the difference between childhood and adult onset lupus?
So childhood, the complications and morbidities are more because growth failure, osteoporosis, and avascular necrosis and all happens.
So basically, see, there are many things in adult onset lupus. So we have that big female to male ratio, no? 8:1 in adult onset lupus. So that ratio you only see in the post-pubertal lupus that happens in children. Approximately at least 20% of lupus begins in childhood. Below what age is lupus very unusual? It can happen at any age, but below a particular age, it is actually very unusual. Below 5 years of age, lupus is unusual. And if you see a child below 5 years of age with lupus, what must you think? What extra thing should you think about?
Drug-induced.
Okay. You should also think about monogenic lupus. Okay. And when a very young child presents with lupus, you have to think about monogenic lupus. It's managed very differently from standard systemic lupus. That's why it's very important to know that. Pre-pubertal children, you have equal male-female incidence for lupus. It's only in the post-pubertal children where you have the female predominance. The other thing is also that childhood lupus is a lot more aggressive than adult lupus. The incidence of major organ involvement is very much higher, very much higher. And because it starts off at a young age, the risk of damage in the long term is also much higher, which means that children need to be treated very aggressively. When they have major organ involvement, the treatment has to be really aggressive and maintained aggressively too, as a result. Okay. And the other thing is also things like cutaneous involvement. There can be variations. We may not see that many children. See, everybody thinks if you see malar rash, you think of lupus. But the important thing is you need to start recognizing lupus even without malar rash, because about 40% of patients will not have, or 60% of patients will not have a malar rash. About 40% of patients will not have any rash. Your patient has no rash, right?
No rush.
So, yeah. So that is the thing. When in the older patients, you tend to see more of the classic presentations. In children, you may not see those classic presentations. So you have to remember all those things. The start at an earlier age, the disease is more aggressive. That is something that we really, really have to remember. And when we say aggressive treatment, we are talking about the immunosuppression. When we say immunosuppression, we are not talking only about steroids. We are talking about the immunosuppressant drugs involved. And we have to be very, very aggressive with these to get the best results for these children in the long term. We'll discuss that in a minute. You want to go to your next slide?
Clinical trial. Treatment given was hydroxychloroquine, prednisolone, and antihypertensive. The child was started on this treatment, referred to a pediatric rheumatologist for further management.
Okay, fine. Right. Good. So what would be the most, once you've done all these tests, what would be the next most priority investigation this child needs? This child needs a renal biopsy. This child needs a renal biopsy. There is no doubt about it. Okay. The fact that your first UPCR was only 0.29 is not a reason. Our indication in pediatrics with lupus is if you have any kind of active urinary sediment or proteinuria or any subtle features in nephritis, go ahead and do a renal biopsy. You can be very much surprised. This could very well be a proliferative lupus nephritis in which your treatment will change. Okay. As I told you, the only other differential diagnosis that can fulfill, once you've done your history examination and presented all the findings, the only other differential diagnosis that would bear thinking about here is the potential of a post mycoplasma immune complex mediated vasculopathy. Okay. And that could be a temporary phenomenon which can get better. But there are many reasons why that is not the case here. And clearly, if you do a renal biopsy, you will also prove whether this child has lupus nephritis or not and what stage it is. Okay. So I'm going to ask you a couple more questions because, as I said, the answer is not over with making a diagnosis of lupus. You should have, what will you tell the parents when you say you made a diagnosis of lupus? How are you going to explain it to the parents?
Child will be actually having a chronic disease, long term, that will require a long-term treatment, maybe a lifelong treatment. And there can be remissions and relapses in the treatment, during the treatment. And we should also advise about the general treatment criteria, such as maintenance of general health. You should give calcium, vitamin D supplementation. You should warn them about infections and aggressive treatment if the child lands up in an infection.
Very good. So
Mhm.
I'll just tell you a few concepts that you need to keep. I think you said a very good thing first, a chronic disease. So lupus is a lifelong disease. Let's not beat any bushes here. You have to, this is one of the first things I tell parents. They have to face that fact. They have to accept. There are a lot of lifelong diseases that children get. Parents have to accept first that this is a lifelong disease. They don't need to be on steroids and immunosuppressants lifelong though. Okay? What you need to do is, you need to initially, once you make the diagnosis, you need to find out what the extent of disease is, and you need to plan the investigations that will define this for you, and you need to plan the treatment based on that. So a child with lupus nephritis, class 3, class 4, class 5, will get a different treatment from a child who just has a lupus with a mild autoimmune hemolytic anemia and a little bit of lymphopenia. Will get a different treatment to that. However, steroids are not lifelong, should never be lifelong. Okay. The other very important thing is, when you once make a diagnosis of lupus, your viewpoint has to go for the long range vision. Okay, you need to have this child survive to becoming an adult, a productive adult who can, have children, have a normal family life, have a career, and have a good productive life. Okay, so right from the beginning, you have to be conscious about control of disease and avoiding damage due to disease and damage due to medication. Okay, this is precisely why these patients should be under a professional who can take care of the things, state of what is current, standard of care has to be given. Okay, treating only with steroids, stopping after some time, restarting again after some time, it's all very bad. You can get a lot of osteoarticular complications, lot of other problems in the long term. There are many standards of care here. Every child should be on hydroxychloroquine. Every child, along with steroids, we usually give steroid-sparing agents. Depends on the indication that we are seeing. There are a lot of concepts like that. But the first thing you have to realize is that this is a lifelong disease. All these remissions and exacerbations actually is something that I will not mention these days. If you control the disease properly and keep them controlled, they don't need to have remissions and exacerbations. They don't need to have it. Okay, they can have a nice, smooth life if they stick to treatment guidelines, if they come to a regular follow-up, and they do instructions as explained. They can actually have a very, very smooth life. If they don't, however, they are both at risk of early, multiple domains. They can get complications both due to disease and due to drugs, and they can have a very miserable future ahead of them. So that is something you need to realize. Sun protection is important. Explaining about a varied, balanced diet is very, very important, because one of the long-term things is that all the things that happen to adults when they get older, like lifestyle diseases, can come much earlier for lupus patients. So they need to have good lifestyle management right from the point of diagnosis and understanding that is also one part of the disease management that they need to know about. Okay, that's a very important thing. As a pediatrician, vaccinations are important. You have to discuss with the rheumatologist as to at one particular point in time what vaccinations are practical. Don't forget HPV virus in this vaccination for these girls. Okay. So there are a lot of all those things that should go in your mind. Again, yes, think of infections when they're on treatment. Get them treated properly, get them followed up properly, and give them a lot of positive support. Okay. That is something the community is actually very negative about chronic disease, particularly in children, even more so in girls. So we have to be their, positive support. We have to give them a lot of encouragement all the time. Okay, that is also an important thing. But the important thing is your patient. Definitely, I would say, from what you have presented, requires a renal biopsy. That is what will determine how we structure the treatment further. When you start steroids right away, you can actually improve many of the external findings you have seen. But if you treat nephritis with steroids alone, the results will not be good. That's why it's important that you can start steroids, but you should also do an early biopsy in this patient. That would be the way I put it. Okay.
Okay.
Anything else? Insight from you first before we take up questions from everybody else. I think we can start the questions very quickly. Dr. Latika, do you want to go through the questions and we can discuss them?
I think you can stop sharing the screen so that.
Excellent discussion and presentation of case. Every aspect has been covered. So it's my comment. I'm sorry I'm giving it much earlier than the questions. Yeah. And of course, I want to say Lancet last Saturday contains seminar on systemic lupus erythematosus. Of course, there may not be anything much more than what they already discussed, but still, in case people are interested, they can go through that. Sorry, sir.
That was an excellent review article. Excellent review article. Yes. Shiji says, can this be a case of either mixed connective tissue disorder or Sjogren's syndrome? I would do a renal biopsy here. With such severe hypercomplementemia, the likelihood of a proliferative lupus nephritis is very high. And your ANA profile has not suggested the possibility of an MCTD or a Sjogren's syndrome. And usually you do get very high ANA theta positivity in both of those. So I think this would just be systemic lupus. Any other questions? I think the other questions in the chat we have actually discussed. Many people have given very correct answers about CRP, rise, and what step next, etc. But any other questions? I'm very happy to take them. Otherwise, we're very close to finishing.
The nice presentation, Divya, and as usual, Dr. Sama. And I like the last part, the transition clinic and handing over to the adult rheumatologists and planning a future life, the career, their education, the immunization. So giving a normal life to her, that is a important, most important part. In the clinical part, in the ultrasound examination, shouldn't we do the Doppler part also, both for the renal and the other vessels also, Doppler also to be included? And what about the investigation for the APLA? Should we do it in all cases? And one
yes, sir. Yes.
evaluation also.
Very good point, sir. I actually forgot to mention, yes, antiphospholipid antibody titers should be estimated in every patient with SLE. And that can also be a cause of nephropathy, actually, in patients. And how that is managed should be different from how a proliferative nephritis is managed. But the other important thing I want to say is when you're doing APLA, so you have tests in the market which says antiphospholipid antibody IgG IgM. Please don't do that. That is a collective test which has very, very little value. You should actually do the three most common and prognostically important antibodies, that is beta-2 GPI, beta-2 glycoprotein 1, IgG and IgM, anticardiolipin IgG and IgM, and the lupus anticoagulant. Okay, so all these three have to be done at the point of diagnosis. Actually, most guidelines recommend that they are also repeated subsequently. It is quite an expensive package. So regarding repetition, I think it's something that you have to be clinically guided by the necessity when you do it later. But APLA is something that should never, ever be ignored. It has significant importance when this girl grows up and is going to be childbearing. It can cause recurrent abortions. It can cause so many complications in the pregnancy too. And that would need to be covered. This will need to be detected prior to pregnancy, and she would need special coverage with maybe enoxaparin during the pregnancy. So these things are all things that have a lot of bearing to how you manage these patients in the long term. What you said about the ultrasound Doppler is very relevant in the way this particular patient has presented. Because when this patient first presented, I think before you did your compliments and all, you don't know what exact cause of nephritis you might be dealing with here. So in that context, yes, doing a Doppler is important. Lupus itself causing renal artery stenosis or things is very unusual. Even with an EPLA, having renal artery stenosis due to a thing is also unusual. But the way this child, the clinical presentation and the initial workup of this child, definitely I think Doppler would have been a good idea as well. Perhaps they already had the complement reports and the other things by then, so they felt it was not necessary. That's what I would think.
Shouldn't we anticipate later treatment with biologicals if in case during the course can
Yes.
situation shouldn't be
Yes.
include
Yes.
hepatitis B status, tuberculosis status, all the immunology
Yes.
problems also.
Yes.
Before
At
this.
baseline. At baseline. Regarding tuberculosis status, before prior to immunosuppression, a MON2 is more or less sufficient and a chest X-ray. In lupus, there is very little place for anti-TNFs, which are the main biologics that reactivate latent tuberculosis. So usually doing an IGRA kind of test in advance is usually not necessary. In some other conditions where we would be using biologics which can potentially reactivate latent tuberculosis, yes, in those patients we would do it. But you can wait for that. I mean, this child I think can be actually, you can start. I would do a renal biopsy and then plan the treatment, the detailed therapy for this patient. And the patient is not responding to treatment as expected, then yes, usually we go for CD19 inhibitors here. That's the class of anti. Of course, there are some very good drugs now which are not available for us. There is an anti-interferon antibody called anifrolumab, etc. That's very good, but it's not available to us. And even if it was, would be horrendously expensive. But we are able to do pretty good job with, with use of initial steroids with concomitant immunosuppressants, hydroxychloroquine, and if necessary, rituximab. We are able to, and some patients requires calcineurin inhibitors, a few other drugs too. So it depends on that. So if you have a patient who presents with,
you said child, monogenic SLE, there is a
Yes,
group of immunological problem with the complement deficiency. I heard.
definitely.
What's your experience in that age group? Did you get any
Yes.
immunological problems complement?
Yes, sir. You can get patients. So the important thing is monogenic lupus is actually not a single group of conditions. There are so many different mutations, and they are from different immunological pathways. So the presentation can be different. So you can have some with skeletal dysplasia, like SPEN-CD, that group of patients. You can have some who present like Aicardi Gutierrez, where they have predominantly CNS manifestations, poor development, etc. Those are function more like type 1 interferonopathies. So through the interferon channel. Then you have the complement deficiencies. They're a different group. And then there are several others too. And there are many other primary immune deficiencies which can have autoimmunity as a part of them. And lupus can be a presentation on the sides. For instance, an ALPS. ALPS can have autoimmunity and can have presentation with lupus or even with a malignancy. So all these things have to be kind of interpreted in the full light of evidence, and then you target which you want to do. And the treatment would be different. How you would treat a type 1 interferonopathy lupus would be very different from a complement deficiency lupus. And how you would treat a SPEN-CD or something like that. So there is it, and under 5, there is a very strong reason that we must do genetics and work up for monogenic lupus too. Not all patients will be monogenic. I mean, I have a number of under 5 patients. The majority of them are not monogenic. If you look at on a percentage basis, the percentage of monogenic lupus with regard to the total population of lupus would be less than 10%, to give an idea.
Thank you. Divya, last point, where is Divya? In the list of your final diagnosis, just like Dr. Suma pointed out, you should have been bold enough to rule out totally few of these things. Actually, there's no need at all to include the rheumatic. So that also was included. Actually, the number of the possibilities at the end, few of them are totally, we could have just avoided that altogether. So it should be bold enough also at the end of examination. Not about the criteria is all. It's not fitting at all. So it's all. Dasai, any more comments from anybody?
At box, are there few more questions?
Dr. Suma, thank you very much for the lucid discussion in such a systematic manner. I had a doubt that is normally for post-streptococcal nephritis, we do a C3 after 6 weeks. Like that in SLE, do we have to monitor the C3 and C4?
So there is this teaching that disease activity in lupus is kind of, we understand disease activity from, one is the disease manifestations that we are seeing. So if you're having anemia, seeing the recovery of that, you're having thrombocytopenia, seeing the recovery of that, nephritis, seeing the recovery of that, etc. Then you have the immunological parameters, and here complement levels and anti-dsDNA. Now, complement levels will improve as you treat lupus. Whether you need to aim to get anti-dsDNA into the normal range, I think that is unnecessary. The only thing is that anti-dsDNA persisting at a high level, even if the patient is well, has got some risk of suggesting that the patient may have a flare of disease. I'm actually less convinced. I don't really check anti-dsDNA that frequently now. The other things I want to say is that we don't ever repeat ANA again. It is not necessary. We are not trying to make ANA negative when we treat lupus. So there is no need to keep repeating ANA and all for these patients. You look at the clinical features that you're treating, you follow up those clinical features, and you follow up the complements, but not after 6 weeks. We usually, maybe I would do, depending on the improvement of the patient, I would probably do it in 6 months rather than 6 weeks. Because there would be enough in that period of time the acute features that I saw at onset, I could be following up the improvement of that. I don't know. I hope that's clear.
In the beginning, there was a small confusion on us. Manjula started actually. You didn't know, and you took over and moved forward. Actually, Manjula is the secretary of Thrissur IAP. So that is why she started, and you didn't know, and you just continued, and you started again in between while she was talking. So
Okay.
our
No problem, sir. Like
apologies.
actually planned that way, sir.
It
Just planned that way.
mistake. That is a small mistake.
Thanks.
Can I make a comment, sir? With your permission?
Yes.
Yes, sir.
I just wanted, because she is having such a good experience, Dr. Suma Balan, for so many years. Okay. So I'm sure she is having quite a number of cases of SLE under treatment. So is there any statistics which you can tell about how many of them have been transferred to adult medical care and this thing? Suma, you have any data
Yes.
to share?
Actually, well, how many of them have been transferred offhand, I can't answer. I mean, we have, I think I would have more than 300 children with
But
lupus.
you're having such a large number of cases.
Yeah, and probably even more, this thing, but more than 300 for sure. And we have also lost patients. This is a condition which can kill, actually.
Yeah, I
and
know.
Many times the patients come to you, in a state where there are a lot of things. So the complications of disease and the complications of treatment, both are things that are significant.
Treatment because of financial this thing.
Yes, that is the biggest problem, because they discontinue treatment. It's not just the financial aspect. The social aspect is a very big element, actually. And disease education has to continue happening every single follow-up visit. It never stops.
Multiple
It has to continue
including
happening.
effusion have seen in a number of cases.
I've seen everything, sir. I think all sorts of presentations.
How common is polycirrhosis?
Not that common, but we have seen a few patients with polycirrhosis. Not that common.
I think you better analyze your data and then publish.
Yes, yes. No, we have actually presented data in different forums and different things, but
yeah, no, I have been
writing. We are doing currently. We have a multi-center lupus nephritis, pediatric lupus nephritis, this registry being maintained, which the first paper is going to come out from that soon.
Thank you. Thank you.
So macrophage activation, someone was asking. Yes, definitely. So any disease where you have, which can potentially trigger cytokine release, and that too on a massive scale, you can get macrophage activation. And lupus can definitely present with macrophage activation, both as a complication of an infection like CMV or as an acute disease manifestation. It has to be recognized, it has to be treated. Personally, I find macrophage activation in lupus easier to treat than macrophage activation in, say, systemic JIE. But it is a significant complication. When we start treating patients, sometimes they can develop CMV reactivation, which can also present like an MS. And those patients will need to be treated differently. Giving them more immunosuppression may not necessarily be the right way to go about things. So that's why you have to be a little careful when we analyze these patients. Yes, ma'am. Dr. Ratti, yes, definitely. I'm sure you would have seen patients with that. So are there any more questions, or shall we
wind up now? Anjusha?
Yes.
No more questions.
Dr. Purushothaman, sir, you have a real eagle's eye to see that growth chart.
Yeah,
Dr.
very
Suma,
true.
we never thought of that. Initially, that when thinking that post-streptococcus glomerulonephritis and arthritis can occur together, that was putting us into a quandary.
Actually, ma'am, I've seen, I still remember a very interesting patient I had, classic phenoxyonline purpura, rash, arthritis, severe bowel involvement, and rapidly progressive nephritis. We had everything. And I was in UK, and in the center I was working in, that particular center didn't do renal biopsies. So this patient was sent to, that time I was working in a secondary center. So this patient was sent to a tertiary center for the renal biopsy. And to our complete surprise, this patient definitely had henoch-Schwann purpura, but his renal involvement, his RPGN, was post-streptococcal glomerulonephritis. So basically, immunological complications, you can have two things in one patient. I've seen last year we had a post-streptococcal glomerulonephritis patient who also had diffuse alveolar hemorrhage, and it was post-streptococcal, both. He had bihypocomplementemia. So these things do happen. So, exceptions make life more interesting, isn't it? No, I just brought that up to spice up the discussion, actually. Your
I
diagnosis
saw
is pakka
Parvati
here.
madam and other seniors, Srinivasan sir, Parvati madam, Saroja madam. Any comments, madam? Srinivasan sir.
Already I made my comments. Yeah. Thank you. Very good presentation, well discussed. And of course, if you have time, you read that recent article SLE in Lancet last Saturday seminar.
Okay,
Of
sir.
course, there may not be anything new, but I think it's worth reading some articles.
Shiji has asked about families where siblings are affected. I don't think you can prevent it, but it can. But if they have the features, then it can be diagnosed early and treated well, so that you don't get damage. Divya, very well presented, very well compiled.
Thank you.
Thank you.
Well
I know
presented.
I attacked you a lot.
Answered
hope-
all the questions also. You are bold enough. Good discussion.